In Part 1, we have analyzed how the epidemic grows exponentially due to the short-term dominance of the infection trap over the balancing loops created by recoveries and fatalities, which only in the long term offer protection by immunity to the susceptible population. In this short term, the only thing that can flatten the growth curve of the epidemic is the behavioral change of the population. We broadly name this behavioral change infection avoidance measures, referring to social distancing and extensive sanitization. This is the Expanding Mindset, discussing systems thinking during the coronavirus lockdown. In the meantime, the more people get infected, many cases require hospitalization due to the severity of the symptoms and end up in hospitals. Some first statistics indicate the cases in need of hospitalization for the novel coronavirus amount to nearly 20% of the infected population, in contrary to 2% for the seasonal flu, and that is a first indication of the seriousness of this epidemic. It's not the purpose of this presentation to drill into the medical details. The rather nice and simple presentation you can find in the coronavirus playlist of our channel if you're interested in that, so check it out. But to make the long story short, we can visualize the basic routing likelihoods for those infected. A. Staying home and recovering, or unlikely pass away if hospitalization is required but doesn't happen in time. B. Getting hospitalized as a non-acute case and recover or pass away if the infection moves fast. And C. Getting classified as critical case and accessing the intensive care where one can either recover or pass away. The recovery and fatality rates moves the opposite direction in size as the patient moves along the three different stages. In general terms, most fatalities result from patients that need intensive care. But hey, we have already mentioned recovery and fatality rates. Let's take a closer look into these concepts, starting with the fatality rate, which is dominating the coronavirus discussion in the media. The registered fatal cases over the infected population produces a fatality rate. Early Covid-19 statistics indicate a range of fatality rate between 1 and 3.4%. The thing is, a country might have a good picture of number of deaths caused by Covid-19, though it's still questionable if they reveal it, but for sure the total infected population is not known as the testing strategy varies from country to country and asymptomatic patients are not tracked at all. Then, by checking figures released in real time so far, we see very confusing rates ranging from 4 to 40% in certain countries. What we have to keep in mind above all the blurriness of those variations is that unlike what common intuition suggests, fatality rate is not a fixed factor intrinsic to the virus attributes related to its ability to kill humans. It is also affected by non-biological conditions, such as the access to modern-day hospitalization, which is a defense that humans are able to deploy, and therefore it is not fixed at all even if we could count all infected population and reveal all related fatalities. Understanding the structure of this subsystem is the main aim of Part 2. In short, the more cases are hospitalized from those in need, including accessing intensive care stage when required, the higher the recovery rate and thus the more people get well due to modern times medical capabilities. Equally, as severe cases access hospitalization, fatality rate drops and fewer people die from the infection. If these severe cases don't find a place in hospitals, then they're going back 100 years, where in absence of the scientific and technological progress of modern days medicine, the Spanish flu epidemic displayed a fatality rate of more than 20% and in places estimated as much as 70%. Well, that's what is happening with Covid-19 epidemic. As patients hospitalized skyrocket due to exponential growth of infected population, they rapidly reduce the healthcare system availability, which is affecting right back the number of cases that can be hospitalized. Very quickly, healthcare system availability reaches its capacity limits, and that results in people that need hospitalization not being able to access it, especially intensive care stage, which in turn result in increase of the fatality rate. When that limit is reached in a regional hospital, what literally happens is that the next person in need of intensive care waits until one person that is inside recovers or dies, with this time being detrimental for the waiting person's health. At that stage, daily fatalities are approximating the daily number of cases requiring intensive care, and patients stuck in the queue are more or less back to the Spanish flu era. So let's now take a closer look into the availability and capacity concepts, which play such a pivotal role in this system. Availability of healthcare system broadly called in the media number of beds, depends on capacity, which is made of medical staff and capital equipment, that is, buildings and machinery. It also depends on the number of days patients occupy a place, which by the way is also a long time for coronavirus patients. As we explained, severe cases require intensive care to keep the patient's respiratory system going. Intensive care units are one of the most capital equipment and operationally expensive sectors of the healthcare systems, with each position costing at least $50,000 in equipment and each day of treatment requiring thousands of dollars in drugs, consumables, and personnel requirements. Nations display a variety of intensive care unit capacity levels, but none of them would ever invest in a capacity to cope with an extraordinary peak in intensive care demand caused by an epidemic that spreads every 1 in 50 years.
We were short hundreds of thousands of ventilators.
So during this extraordinary epidemic, they have been trying to boost up capacity by building and equipping new hospitals at only a few days, like in China, or transforming buildings into hospital wards as we've seen in Madrid and elsewhere. But boosting up capacity has also limits, as equipment manufacturers' production capacity is also geared up to run in slower pace during normal times. Let's connect our systems thinking model so far with the flatten the epidemic curve concept, which has become a popular motto and picture in the media, though not always fully understood by the masses. Let's say this is the epidemic curve of a normal virus outbreak, such as the seasonal flu. Time passed since the first case is depicted in the horizontal axis and number of infected population is depicted in the vertical axis. Cases grow as time passes at exponential rate due to the infection trap loop, then they drop due to the immunity balancing loop. In many countries, healthcare system capacity has been built up through the years to top the peak of such normal outbreaks. Thus, most cases that need intensive care find a place in hospital, and fatalities are limited to cases that cannot be saved even by this ultimate medical defense that humans have developed. However, Covid-19 infection trap grows the cases in such a pace that before immunity kicks in, availability of intensive care places runs out, leaving all cases above the line and requiring such care to turn into fatalities. So flatten the curve motto refers to the behavioral change of social distancing and sanitization practices which slow down the growth that infection trap produces. Unless a vaccine is produced, most likely the same total number of people will get infected, but the peak of the curve will be lower as fewer people will be infected at the same time. Thus fewer people will need hospitalization at the same time, and equally, fewer people will be left out of intensive care when needed. In addition, that slowdown gives time for the healthcare system to boost capacity to a higher level and possibly be able to facilitate intensive care for all in need. Thank you for watching. Remember to check out supplementary materials and stay tuned for part 3.